Lateral ankle sprain or inversion sprain by Molly Tarter and Taylor Schwartz. This presentation covers an acute lateral ankle sprain and not a reoccurring ankle sprain, which should be treated differently. In this presentation, we will be discussing the prevalence, diagnosis, common signs and symptoms, common clinical findings, the PT interventions, prognosis, and outcome measures for a lateral ankle sprain. Just a quick anatomy review. The three ligaments injured in a lateral ankle sprain are the anterior talofibular ligament, the calcaneofibular ligament, posterior talofibular ligament, along with the surrounding lateral soft tissue structures. This injury may or may not be accompanied with a fracture. Ankle ligament injuries constitute approximately 5 to 24% of injuries occurring in an individual sport, and 10 to 28% in running and jumping sports. Most acute lateral ankle sprains are in 21 to 30-year-old individuals. Lateral ankle sprains account for 85% of all types of ankle sprains. The ATFL is involved in 60 to 70% of all ankle sprains. The diagnosis of a lateral ankle sprain. There is no single symptom or test that can accurately diagnose a lateral ankle sprain, but this cluster of findings listed above can be strongly suggestive for a lateral ligament rupture. The cluster includes extensive swelling at the time of injury, pain on palpation, presence of a hematoma, positive anterior drawer test, impairment with walking. An X-ray or MRI may also be taken to rule out a fracture or soft tissue injury. The West Point ankle sprain grading system includes the following. Grade 1 shows tenderness over the ATFL, minimal to no swelling, stretched ligaments, and minimal instability. Grade 2 shows tenderness over the ATFL and CFL, local swelling, diffuse lateral tenderness, partial tear of the ligaments with slight instability. Grade 3 shows tenderness over the ATFL, the CFL, and the PTFL, significant swelling and pain, ecchymosis, complete rupture of the ligaments, and definite instability. Signs and symptoms of a lateral ankle sprain include the following. Pain, especially with weight bearing, edema, potential bruising, decreased range of motion, especially in dorsiflexion, tenderness to palpation over the lateral aspect of the ankle, antalgic gait, and the mechanism of injury. The patient will most likely report landing with the ankle inverted and plantar flexed. A link for the video showing this mechanism of injury is provided for you. Clinical findings of a lateral ankle sprain include the following. The subjective history, including the signs and symptoms and the mechanism of injury, will indicate a lateral ankle sprain. The Figure 8 test for swelling shows an increase in size in the involved ankle shown in the picture above. Ottawa ankle rules can be performed to rule out a fracture. These rules have a high sensitivity used to rule out the fracture when the tests are negative. Radiographs of the ankle are indicated if there is pain to palpation approximately 6 centimeters above the medial or lateral malleoli, or inability to bear weight after injury. Radiographs of the foot are indicated if there is pain at the base of the 5th metatarsal or the navicular, or there is an inability to bear weight after the injury. Patients will also have an abnormal gait pattern with decreased stance phase on the involved ankle. Special tests include the anterior drawer test, which tests the integrity of the ATFL, calcaneal tilt test, which tests for general lateral ligament integrity, and the Taylor test, which tests the integrity of the CFL.
Depending on the literature, there are 3 or 4 phases during the healing process of a lateral ankle sprain. The goals of each phase are listed below. The goals for Phase 1 are pain and edema control, while the goals of Phase 2 include increasing strength by lower-level strengthening techniques and increasing range of motion. Phase 3 includes improving dynamic balance and proprioception, and the goal of Phase 4 includes functional training and return to sport or daily activities. RICE, or rest, ice, compress, and elevate, is key during Phase 1 of a lateral ankle sprain. Modalities including electrical stimulation, ultrasound, and cryotherapy should be chosen in order to decrease pain and swelling. Early exercises can be included during treatment or in a home exercise program. These exercises will promote circulation throughout the involved limb while maintaining the strength and motion the patient still has. Some examples are toe curls and ankle pumps. However, these exercises should be performed in pain-free limits to avoid further damage to surrounding tissues. Temporary immobilization can also be implemented in patient-specific treatments. These can include non-weight-bearing with crutches or a splint, boot, or brace. According to a systematic review done by Pearson et al., a short period of rest in a below-knee cast helps to reduce pain during the early inflammatory phase of biological ligament healing. In Phase 2, the patient is able to partial weight bear without pain in the involved limb. Exercises during this phase focus on lower level strength, which can include, but are not limited to, TheraBand, isometric exercises, and seated closed kinetic chain exercises. Some examples include marching, heel raises, and supine leg press. Range of motion loss should be treated with active assist range of motion and/or joint mobilizations, especially for dorsiflexion. Recommended activities include balance training and double heel raises as well. By Phase 3, the patient is full weight bearing during ambulation. Exercises in this phase include standing balance training, standing double heel raises, and open kinetic chain resistive exercises. Treadmill walking can be added here, as well as cycling for controlled ankle range of motion. Range of motion emphasis is still on dorsiflexion due to the fact that this range of motion is most lost during an acute lateral ankle sprain. At this point, full passive range of motion should be achieved. Long-sitting gastrocnemius stretches can also be added to promote ankle dorsiflexion, which enables a normal gait pattern. By Phase 4, the patient should be walking at a fast, pain-free pace. Examples of exercises include a single leg stance, step-ups, lunges, backward step-ups, shuttle runs, and shuttle maneuvers. Patients can be progressed through a walk, jog, run progression. Sport-specific training as well as plyometric training can be started in this phase. One example of a plyometric exercise used in ankle stability is the ankle hop, which includes a 2-foot hop, a single leg hop, and a multidirectional hop. The prognosis for a lateral ankle sprain is good compared to any other musculoskeletal condition. Lateral ankle sprains are inversely proportional to the severity and grade of the injury, meaning the larger the grade, the worse the prognosis. Age and rate of reoccurrence are factors that play a role in the prognosis of an individual with a lateral ankle sprain. Younger patients do not do as well, and the prognosis is worse when the ankle has been previously sprained. Conservative interventions have been found to be consistently effective in treating grades 1 and 2. Grade 3 sprains do not have as good of a prognosis as grades 1 and 2, with only 20 to 60% of patients being symptom-free after 1 to 4 years. Some examples of outcome measures for the foot and ankle include the Ankle Joint Functional Assessment Tool, the Functional Foot Index, the Foot and Ankle Ability Measure, and the Lower Extremity Functional Scale. The Ankle Joint Functional Assessment Tool is a patient-reported outcome measure of the ankle's functional ability. This outcome measure is out of 48 points. The MDIC could not be found. However, the scores that the patient should achieve are listed on the slide. The Functional Foot Index consists of 3 subcategories: pain, disability, and activity. This is a self-reported outcome measure. The MDIC is 7 points. The foot and ankle ability measure. The MDIC for the foot and ankle ability measure is 8 for patients who perform normal activities of daily living, while the MDIC for an athlete is a 9-point change. The lower extremity functional scale includes 20 self-reported items assessing activity and participation of the whole lower extremity. The MDIC for this outcome measure is 9 points.
Here is a list of our references. This concludes our presentation over the lateral ankle sprain.